Good afternoon, everyone, and welcome to the Melanoma Research Foundation Ask the Experts series. We are thrilled to have you join us today for this wonderful educational program brought to you by the CureOM Initiative and Castle Biosciences. My name is Kyleigh LiPira, the CEO of the Melanoma Research Foundation, and I'm so thrilled that you are all here to tune in and learn about diagnostic and genetic testing for ocular melanoma. So to kick things off today, I just wanted to share a little bit about the MRF. This month actually is the MRF's CureOM Initiative is promoting our national awareness campaign, #IGetDilated, in honor of Eye Health Awareness Month. For those of you who don't know, over 2,000 Americans are diagnosed each year with ocular melanoma. And although this cancer is considered rare, it is the second most common form of melanoma. And getting a yearly dilated eye exam is the only way to detect ocular melanoma early. Hence, #IGetDilated. So this month, we're really excited to help educate our community. And we have several events coming up in addition to our Ask the Expert series that you're all watching today. We'll be having our 9th annual Patient and Caregiver Global Symposium that's coming up November 19th through 21st. And again, it will be held virtually this year, unfortunately, as we all know. This 3-day event is filled with really helpful information. It's pre-recorded and live content. It's for newly diagnosed patients as well as current patients and their care partners. And we're really focused on providing opportunities for education, support, and connection with the ocular melanoma community. So we'll have a lot of great sessions. A lot of experts are donating their time and expertise to speak to our community over these 3 days. So we hope you will register. Registration is free. So that brings us to today. And again, we are really excited to host our first Ask the Expert series for ocular melanoma. As you all know, education is so critical for patients in making informed decisions about their care. And we're really thrilled to partner with Castle Biosciences on this important program, which is really touching on topics to help educate and empower patients in the ocular melanoma community. So today is our first session in the series, and we'll be focused on understanding genetic testing. The session is streamed live, which you're all watching, on our Facebook page, and then it'll live there in our video library. So feel free to continue to share this information with your network. We also encourage people to use the comments section of the Facebook page where you can ask questions while you're listening today. We're going to address all the questions at the end, but we just want to make a note that, again, today's session is for educational purposes. Any treatment questions should be addressed directly with your healthcare provider. So we also encourage you to visit melanoma.org, which is the Melanoma Research Foundation's website, where you can learn more about ocular melanoma and the resources that are available to you. So with that, I am very pleased to introduce our speaker for today, Dr. Basil Williams, who is the Mary Knight Ashbury Chair of Ocular Oncology and the Assistant Professor of Ophthalmology at the University of Cincinnati College of Medicine in Cincinnati, Ohio. He completed his residency, vitreoretinal fellowship, and his chief resident position at the Bascom Palmer Eye Institute in Miami, Florida. He then went on and completed his ocular oncology fellowship at Wills Eye Hospital in Pennsylvania, which many of you are very familiar with. His research interests pertain to adult and pediatric surface and intraocular tumors and vitreoretinal surgical topics. So with that, I am very pleased to pass the baton over to Dr. Williams to talk to us about understanding genetic testing.
Kyleigh, thanks so much for that wonderful introduction. I also wanted to thank you all for the opportunity to speak with you today. And I just pulled up my slides here. So I'm Basil Williams from University of Cincinnati, and I just wanted to talk a little bit with you today about understanding genetic testing in uveal melanoma. So thankfully, ocular oncologists have figured out a way to do a good job at treating the eye portion of uveal melanoma. We have a local cure rate of greater than 95%, whether that's done with plaque radiotherapy, the picture seen at the top, where you have localized radiation that works its way across the wall of the eye, or in proton beam radiation. Unfortunately, up to 50% of patients still experience metastasis, and this is usually to the liver, and it happens often within the first 5 to 10 years. Now, we know that we're treating the tumor well with good response rates, but we're still having this rate of metastasis. Only about 3% of patients have metastasis at the time of diagnosis. And so that lets us know that there's probably some level of micrometastasis that's happening immediately, basically meaning the tumor is sending out cells to other parts of the body, primarily the liver, early on. And so we really want to figure out how we can identify which patients are at most risk for that so we can appropriately follow patients in the future. Now, previously, we were using certain clinical or pathological findings in order to address these risk factors. And based on this information, the patients with the lowest risks had about a 12% 15-year mortality rate. Well, that's actually pretty high, and we know that we can identify or find ways to show that information better. And instead of having all patients undergo very intensive surveillance looking for spread to other parts of the body, which was done historically, we wanted to figure out ways to identify patients individually, because every patient wants to know what their risks are. So how do we do that? We basically want to look at the genetic information of the tumor. And in the same way your genetic code individualizes you as a patient, a tumor's genetic code does the same thing. So back in about 1990, we learned that chromosome 3, if it was in monosomy form, so basically only one of those arms, increased the risk of metastasis. More recently, we've learned there's basically 4 chromosomes that we want to pay attention to. Now, this is shown to be helpful in determining who's at risk for metastasis, but hasn't been prospectively validated. Looking at the tests from Castle Biosciences, we have 3 options that kind of work together to help give you the most information prognostically. I want to talk first about the first test and the mainstay of testing, which is prospectively validated, and that's the DecisionDx-UM. And then I will talk a little bit more about PRAME and sequencing in a second. So this was prospectively validated by the Collaborative Ocular Oncology group, incorporating physicians across the country. And basically, they took patients with uveal melanoma and did biopsies. And the results of those biopsies were then analyzed and the patients were followed. And we realized that patients basically broke into 2 classes. About 60% had class 1, and as you can see on the graph here, there's a low chance of metastasis over time, versus class 2, where there was a high risk of metastasis. Now, there's obviously a lot of studies here, and it's a busy slide, but the point of this is that multiple other centers have looked at this information and validated the fact that there is a difference between the class 1 and class 2 profile, with class 1 lesions rarely leading to metastasis, and class 2 lesions often leading to metastasis. And so that information is really valuable when doing the biopsy. What we later realized is that looking at class 1 lesions, there's a certain percentage of them that seem not to lead to metastasis very often, and that turns out to be the class 1A, and then a subset that does lead to metastasis, not quite as quickly developing as class 2, and not always to the liver the same way as class 2. And so the decision was to look more into that to help determine more details about why that is. But based on this information, this is one of the reasons why this test is done in almost 3/4 of the tumors done across the country. And it is important to note that 96% of the time a biopsy is performed, enough material is obtained in order to give this genetic result. And so what would you see if you were to get a biopsy? You would get this information where it shows you that it's a class 1A lesion, and it shows you how valid that information is. Now, we know that class 1A lesions are somewhere around a 2% risk of metastasis versus 1B being around a 20% risk versus class 2 being over a 50% risk. Now, how does that information help us? Well, we know using the old approach, we knew patients had in general about a 50% risk of metastasis, and even those with early disease had about a 12% risk. And that put us in a situation where everybody was undergoing high intensity management. Based on the characteristics that we have now, we know which patients are likely to get metastasis, and we can therefore adjust our systemic surveillance based on that information. So if you have a class 1A risk, which is very low, then we don't need to check the rest of your body as frequently. Versus a class 2 risk, where the risk is high, we do know that we want to follow more closely so that we can identify the metastasis at an earlier stage. Additionally, because in class 2, the risk is so high for metastasis, we then want to look into potential adjuvant clinical trials where we can find medications or potentially find medications that will help reduce the risk of that metastasis. And so this is kind of where we currently stand as far as what's prospectively validated. But we also wanted to determine, well, what's going on in this class 1 difference that we see between 1A and 1B? And so in analyzing the difference, we were able to find something called PRAME, or preferentially expressed antigen in melanoma. And what we realized is that for class 1 lesions that did not have PRAME expression, the chance of metastasis was very, very low, versus class 1 lesions that did have PRAME. Additionally, PRAME played a role in class 2 lesions causing earlier metastasis from the time of diagnosis. So based on this information, we see that PRAME plays a role not only in differentiating class 1 lesions, but also in terms of when metastasis may develop in class 2. And this is something that is being studied now by the Collaborative Ocular Oncology group in their second study, and I'll highlight some of those centers in a little bit later. So the last component of genetic testing at this point is sequencing. And that's basically where we're looking at different genes that contribute to the development of a melanocyte going from a regular cell and turning into a melanoma. So we have our initial step here, where the G proteins can turn a regular melanocyte into a nevus or a mole. And then we have our second set of mutations, and that helps determine whether or not you're at high or low risk. And we're working on trying to identify good treatment options to attack those locations. And so basically moving forward, we would like to take this information to find treatment targets. So moving forward, we can work on this disease process at a better level. And this is something that is also not prospectively validated at the moment, but the information is new and fresh, and this is something that is very helpful moving forward. Now, lastly, patients really want to know, well, we know why we're doing the testing and we know what information it provides us, but how is the testing actually done? So fine needle aspiration biopsy is the method that we use to obtain a sample or specimen. And basically, if the tumor is near the front part of the eye, we come across the wall of the eye with the needle directly into the tumor. And if it's towards the back part of the eye, we go across the wall of the eye. So we know there are some risk factors that are associated. You can get hemorrhage that lasts in about 5% of cases. Even though bleeding happens at the time of biopsy, the vast majority of cases, the blood goes away on its own. Retinal detachment can occur, but that's less than 1%. And then the scary things like infection or spread of the tumor outside the eye are significantly lower than 1%. And in multiple scenarios, it's been evaluated and demonstrated that there is no evidence to suggest that fine needle aspiration biopsy increases the risk of metastasis. And so to kind of address some of the myths or concerns that patients may have, just want to say, will tumors spread outside the eye and cause metastasis? Overwhelmingly, the evidence suggests that no, that is not something that will happen. What about retinal detachment, bleeding, or losing vision? As I said, bleeding can happen at the time of biopsy, but the vast majority of time it goes away on its own, requiring only intervention in about 5% of cases, and retinal detachment, again, is very rare. Lastly, will adequate cells be obtained for analysis? So 96% of the time a biopsy is done, we're able to get enough information to give the results of the gene expression profile testing and to give you that information for prognostication. So I think that goes over some of the reasons about why we do the genetic testing, what it means, what we're looking forward to in the future, and how the process is done. And lastly, the Collaborative Ocular Oncology Group is currently made up of a number of ocular oncologists across the United States and Canada, and we are looking into the relationship between gene expression profile testing, the classes, and PRAME to prospectively validate that information as well. And we look forward to finding out more information from that perspective and then sharing that with you all in the future. Thanks so much. Happy to take any questions.
That was wonderful. Thank you so much, Dr. Williams. And we actually got a whole bunch of questions in during your talk, and we have a couple additional ones that people had asked ahead of time. So let's just start with this one. If the test was not available when someone was diagnosed, or they were overwhelmed at the time and they chose not to have the test, can they still go back and get genetic testing?
So I think that is one challenging situation. From the prospective validation standpoint, these tests were done on patients who had the biopsy done prior to radiation, because we know radiation can affect some of the genetic results. So the best scenario is to have the biopsy done prior to radiation. And then even if the decision is made that you don't want that information analyzed yet, as long as the biopsy is done, that material can be held and then can be analyzed later on in case that decision to move forward with it is made.
And genetic testing has been out for a while in general in the oncology world, and we've certainly heard a lot about it in breast cancer. What is your thought in terms of the accuracy of the genetic testing? So if somebody is considering it, how accurate is it?
Yeah, so I would say genetic testing for ocular melanoma, for uveal melanoma in particular, is fantastic. That is one of the things that was really helpful about the Collaborative Ocular Oncology Group first study, and then a number of series that have come out afterwards. They have really validated that it is a highly accurate study, giving patients good information about their prognosis.
That's great. So people can feel confident if they get genetic testing with the results.
Absolutely.
Great. So maybe you can tell us a little bit about this percentage breakdown of patients being diagnosed in class 1 versus class 2. Is it overwhelmingly in one or the other?
Yeah, so I would say that the vast majority of patients, about 2/3, are in the class 1 category. And so that means that they're at lower risk of spread compared to about, mid-30s for the class 2. And then when you're looking at a breakdown of the class 1 lesions, if you separate those, about 2/3 of those are on the class 1A side, on the lower risk, versus the class 1B side.
Great. And so this is kind of an interesting question, and one that I've certainly had as well. Is what is the difference between genetic testing and genetic screening, or is there a difference?
Yeah, so I think that's a phenomenal question. So when we're looking at genetic testing for uveal melanoma, we are making the diagnosis of a melanoma, and we are doing the testing looking at prognostication for what may happen in the future. When we're looking at genetic screening, we are looking at certain markers in the body to determine if you are at risk for developing something in the future. Now, that brings up a really good point when it comes to uveal melanoma. We do know that there is a genetic component associated with uveal melanoma that was discovered somewhat recently over the last 5 to 10 years. It's called BAP1 germline predisposition syndrome. And it's basically a condition where you might be at more risk of developing certain types of cancers, including uveal melanoma, skin melanoma, mesothelioma, or renal cell carcinoma. And in those scenarios, you can do a blood test to determine if you have the likelihood of passing that, if you have that condition, and if you have the likelihood of passing it on to family members as well.
And is that a different type of is that a blood test to determine that?
That
Okay,
tends
so
to be a
that's
blood test or can be done by swab.
okay. And would a patient just request that of their physician, and they would refer them? How does something like that work?
Yeah, so that is a really good question for the physician and patient to kind of determine together. So, because it is not something that is overwhelmingly common, we do look for it in specific situations. So, if patients have a strong family history of some of those cancers that I've mentioned, or if they're really young and out of the normal age bracket where we would expect uveal melanoma, that would mean that there is a higher chance that there might be an underlying predisposition syndrome. And so, in that scenario, a patient definitely could bring it up to the physician, and often the ocular oncologist will bring it up as well. And that can either be done in a take-home test where the patient can swab and send it out. And many places also have genetic counseling where they're able to do it in-house and then offer some conversation about the meaning of the test as well.
So you brought up something really interesting. You said the normal age bracket. So is there kind of a typical age gender that somebody with uveal melanoma would fall into, and what would be kind of alarming where you're like, you don't fit the typical description of somebody with uveal melanoma?
So first, I will say that uveal melanoma can happen in any age. The youngest patient that we've seen here has been 4 years old, and the oldest patient we've had has been 98 or 99. Most commonly, the age range is somewhere in the early 50s to late 60s. So somewhere around 60 is what we would be normally expecting. Once we start getting younger than 50, I do start to think a little bit more. I wonder if there is another reason that could potentially be causing this.
Okay, and that's when, like you said earlier, you would look into those genetic screening tests and some other things as well, thinking outside the box.
Exactly,
So
absolutely, to determine if there's a different reason.
good. Okay. So we had another question come in. So what is the definition of class 1A, 2, and 2B, and how do those break down regarding metastases? And I know you touched on this a little bit in our presentation, but maybe you could just sort of very simply define those three classes and again, talk a little bit more about metastases.
Sure, absolutely. So I think that's a great question to highlight the importance of this. So, class 1A is the lowest risk of spread. And so the way this test is done basically is you get a sample of the tumor, and there are 15 genes that are analyzed to see if they're high or low in your sample. And based on the characteristics of that, it lets us know how high risk or low risk the lesion is. And so a class 1A puts you at about a 2% risk of spread over 5 years. A class 1B puts you at about a 20% risk of spread over the first 5 years, whereas a class 2 lesion puts you at a greater than 50%, actually somewhere around 70% risk of spread over 5 years. So those are the different categories that we have.
Great, thank you. And obviously, once a patient has this test, then they're working with their ocular oncologist on surveillance and really working with their treatment team if they are high risk.
Yeah, and so I think that again, determining the best way to approach those situations is really a good conversation for the ocular oncologist and the patient to determine what's the best option for them. Oftentimes, a primary care doctor is following to do systemic surveillance or a medical oncologist as well. If you're in the class 2, where it's a high risk of spread, there's a possibility of some clinical trials that are available to attempt certain medications to see if that will reduce that risk of spread. Some patients prefer to go down that route. Some patients prefer to go down the surveillance route and examining the body at regular intervals. And I think that's a little bit of an individualized decision. One other thing that I wanted to say in regards to the first question that you asked about if you didn't have a biopsy at the time and then you decide later on if you want it, I think it's also important to say that some patients in the past may have had genetic testing done, and uh, Castle tries to keep some of those samples or some of that sample around, so that way we could possibly look at future stuff down the road. And so potentially things like sequencing could be assessed later on.
That's a really good point. So somebody got the test and they never really did anything with the results. They could always circle back to Castle and link up and make sure that that information is being utilized in their treatment plan.
Absolutely. And I think that's something that's going to be really valuable moving forward. As we learn a little bit more about treatment options and better ways to take care of patients, having a little bit of that material to analyze later on will be helpful.
That's great. We are getting some more questions in. So I know we're going to be wrapping up in a few minutes. I have a couple more I wanted to ask you. So what is the meaning of a positive PREAM test?
Right. So I will say that anecdotally, at least from some of the information that we have in our studies, when PRAME is positive, it seems on class 1 lesions to mean that you're more likely to have metastasis. And on class 2 lesions, it seems that when metastases happen, they happen at an earlier stage, so closer to the time of diagnosis. Now, as I was saying, it is not prospectively validated yet. And so that is something that the Collaborative Ocular Oncology Group is currently working on to make sure that we know all of the details of that information. But at least as of now, it seems that it increases the risk of metastasis.
Okay. And last question, as we're wrapping up here. So we often hear about patients saying, oh, I have a freckle in my eye, or I have a nevi in my eye. You know, what is your thought of proactively biopsying something like that versus waiting and seeing? What should patients know if they have a nevi in their eye that would be important for them if they are just watching it?
I think that's a fantastic question. I know that when patients are diagnosed with a nevus, it can be really concerning because of the potential risk of spread. And so a lot of patients have some anxiety about what that means. I think continuing to have dilated exams by your ophthalmologist or ocular oncologist is the most important step to make sure that if any changes are happening or if there's a possibility that it's transforming, that things can be treated immediately. When it comes to biopsying, that can be a little bit of a challenging situation. While we know that the results are 96% success rate or technical success rate, there's a lower success rate for thinner lesions. So the smaller the lesion, the more likely it is that you won't get information. And so if clinically the lesion appears to be a nevus, following it makes good sense. Sometimes doing a biopsy on a lesion that's really, really small, you may not get a lot of information from that. And so I think usually following the ophthalmologist guidelines of assessing the tumor clinically and then doing a biopsy if either it's a suspicious lesion or it's a melanoma tends to be the best approach.
Great, thank you. And our last question of the day, and I think this is a really important question, but does the test assist in projecting metastases after the 5-year mark?
So I think that's a really good question. And I think that's something that we still have to get a little bit more information on. We do know that patients are at risk of developing metastases after the 5 years, but as far as the reports at this point, it's focused on those first 5 years.
Great. Thank you so much, Dr. Williams. So with that, we will wrap up our first Ask the Expert series session here with Dr. Williams. I want to thank you again so much. Your presentation was incredible. I think so helpful to the ocular melanoma patient and caregiver community. And thank Castle Biosciences for their generosity in sponsoring this series during our #IGetDilated Awareness Month. Before we sign off today, I just wanted to highlight a few resources that the MRF has. Again, on our website, we have information on genetic testing on the melanoma.org website. Again, we have a whole section on our CureOM initiative that provides education resources for newly diagnosed patients and caregivers, as well as support services as well. So please check that out. Again, a reminder about our CureOM patient and caregiver meeting that is coming up later this month. It is free to register. Again, we would encourage people to visit our website and register for that as well. It will be held virtually, but we're bringing in amazing subject matter experts from all over the country, in fact, all over the world to participate. It really will be an international meeting. So we hope you will join us. And also, we wanted to highlight our upcoming session for Ask the Expert. This will be next Tuesday, November 10th at 4 p.m. Eastern. We'll talk about standards of care in ocular melanoma, and that will be with Dr. Prithvi Murathanjaya. So I hope you will all join us. And again, if you need anything or have any further questions, please feel free to email the Melanoma Research Foundation and we will get back to you. Thank you so much. And thank you again, Dr. Williams. Have a wonderful day.
Thanks so much. Really appreciate it.